Diagnosis and the management of croup. Croup is a common respiratory illness of the larynx, trachea, and the bronchi that leads to respiratory stridor and a barking cough. Laryngotracheoids, laryngotracheobronchitis are included in the croup spectrum and affect 3% of children from 6 months to 3 years of age. This is barking cough of croup.
Okay.
Epidemiologically, it occurs predominantly during the fall and the winter. It is more common in boys than in girls. The incidence of croup is highest between 6 months to 3 years of age, but it can occur in children up to 6 years of age or earlier than 6 months in atypical cases. But the typical age is from 6 months to 3 years of age. Less than 5% of all children with croup are hospitalized, and of those who are hospitalized, only 1 to 3% require intubation. Viruses are detected in up to 80% of patients who have croup with identifiable pathogens. Parainfluenza virus, especially type 1, is responsible for croup. Parainfluenza overall is responsible for up to 75% of all cases of croup, and human parainfluenza virus 1 is the most common type from 1 to 3. Other viral etiologies include influenza A and B, adenovirus, RSV, rhinovirus, and enterovirus. Viral infection of the subglottic region and the laryngeal mucosa causes inflammation and edema, which significantly decrease air movement and lead to respiratory distress and stridor. Bacterial croup is less common and might be caused by Mycoplasma pneumonia and Corynebacterian diphtheria. The type of infectious agent does not affect outcome or initial management. Whether the cause is bacterial or viral, adenovirus or parainfluenza virus, it does not affect outcomes or it does not affect the management. Viral croup often presents similar to an upper respiratory infection with 12 to 72 hours of low-grade fever and coryza. For 1 to 2 days, it looks like flu-like illness. Narrowing of the larynx leads to stridor, increased respiratory rate, respiratory retraction, and a barking cough. Symptoms might be exacerbated by emotional distress, are worse at night, and peak between 24 to 48 hours. Croup typically resolves spontaneously within 48 hours. Croup is primarily a clinical diagnosis, with typical finding of abrupt onset of a barking cough, respiratory stridor, and hoarseness. Many patients will also have dyspnea and fever, but the absence of fever should not reduce suspicion for croup. Respiratory rate is often increased in patients with croup. Additionally, patients can present with tachycardia and a low oxygen level. Visual inspection can reveal clues to the severity of illness. Retraction and nasal flaring may indicate more severe cases. Although cyanosis is absent in most patients with croup, its presence suggests severe disease. If there is cyanosis, it is severe. The most common auscultatory finding is overt inspiratory stridor. If wheezing is present, it is typically mild. Substantial wheezing should prompt evaluation for alternate diagnosis, but scattered mild wheeze can be there. Bronchi may present but are not typical. Rales are generally not present in croup, so if there is rare, this finding should prompt further evaluation. Laboratory studies are seldom needed to diagnose croup. Although radiographic image is not routinely indicated, croup is often associated with the steeple sign, which indicates glottic and subglottic narrowing. However, this finding is neither specific nor sensitive for croup. Computed tomography of the neck can be considered for patients with suspected abscess, tumor, or foreign body aspiration. Laryngoscope should be reserved for atypical presentations or when alternate diagnoses are suspected. If epiglottitis is suspected, Laryngoscopy should be performed with caution because of concern for rapid airway obstruction. But epiglottitis is associated with severe airway obstruction, toxic appearance with high-grade fever, drooling, and triploid appearance. Management of croup is based on the severity of the illness. Although scoring system is not necessarily, the most widely studied and commonly used is the Wesley Croup score, which is based on air entry, retraction, stridor, cyanosis, and the level of consciousness. Grading based on those criteria will help us to assess croup as mild, moderate, and severe. If the score is between 0 to 3, it is mild. If it is from 4 to 7, it is moderate. Above 7 is severe croup. Oxygen should be administered to children with hypoxemia or severe respiratory distress. HaloX is a helium and oxygen mixture used for respiratory conditions that theoretically improves airflow resistance by decreasing gas density. Helium is a low density gas. Corticosteroid is the backbone of management for croup. Corticosteroid should be used in patients with croup of any severity, whether it's mild, moderate, or severe. Treatment with dexamethasone results in faster resolution of symptoms and a decreased return to medical care. Corticosteroid work by decreasing laryngeal mucosal edema through their anti-inflammatory effect. Dexamethasone is the preferred corticosteroid because it is given as a single dose and can be given orally, intramuscularly, or intravenously. 0.6 mg per kg is the most commonly used dosage. Compared with prednisolone, dexamethasone used in the emergency department or hospital may decrease rate of return visits or readmission. However, a community-based randomized trial found no difference between single-dose dexamethasone and the 3 daily doses of prednisolone for treatment of mild to moderate croup. But since dexamethasone is a single dose and it can be given different route, it is commonly preferred. Epinephrine is thought to improve symptoms in patients with moderate to severe croup through arterial vasoconstriction in the upper airway mucosa, which eventually leads to decreased edema. Epinephrine is typically used in conjunction with corticosteroids because it has a quick onset of action but a short half-life, whereas corticosteroids have a slower onset of action but a longer half-life. So, epinephrine is used for rapid improvement of the symptoms but has short half-life, so it should be given with corticosteroids. The recommended dose is 0.05 ml per kg of epinephrine in 2.5 ml of normal saline. This is a summary of Croup. Thank you for watching and also for subscribing.